So it's, thank you, Guillermo. Guglielmo. See, I've been using Guillermo way too many times because of our organizer here. We have a different Guglielmo here as our chair. Thank you very much, Guglielmo. The rooms are practically identical, so I'm used to the podium next door, which is where we have the public health workshop, and the position of the slides is somewhat different. This is a session on screening for prevention of cervical cancer for developed countries, and I was asked to give the presentation on principles of screening and give the overview, particularly on where it has worked, where it seems to have worked well, and where it has not. And to be able to get to that, we have, of course, to go over the principles of screening. I don't have any conflicts of interest, but I have lots of associations with the industry, and I'm damn proud of it, with the opportunity I have to influence. If I can actually just take a couple of seconds here to say, if there's one thing in my legacy that I leave to this community here, is not so much for my research, but my ability to influence the industry that has given so many good products for women's health. So over the next few minutes, what I would like to do then is to cover the requirements for cervical cancer screening to be maximally effective. And this is pretty much textbook information with respect to how screening is organized. And cervical cancer is the paradigm, of course. We don't have as much experience with other cancers in screening in terms of organization as we do with cervical cancer, which we have decades of experience as a global community. Show the evidence that screening is effective, and that's not evidence from randomized controlled trials. You see what kind of evidence that is. It's from observational studies. And then introduce you the opportunity we have to monitor incidence and mortality trends to obtain evidence that for the impact of cervical cancer screening. But then there are some caveats in interpreting time trends of screening. And what I will not cover, although I would love to do that, but that's going to be for other speakers, would be to talk about technology, age at start and discontinuation of screening, frequency and impact of HPV vaccination, which should be the topic, and certainly one cannot ignore that to talk about the impact of cervical cancer screening. Going back to the basics here, if we look at the encyclopedic knowledge we have on this, and the World Health Organization via the IARC has established some of the guidelines and defining the guiding principle here, the goal that we have, and uniquely for cervical cancer screening, more so than for other cancers, the purpose of screening for cervical cancer is to prevent the appearance of invasive disease by the detection and treatment of precursors, so precursor lesions. We have a unique opportunity to do that with cervical cancer, not so much for other cancers in which screening is shown to be effective. There are two models to be able to implement screening, and next door we had quite a bit of that with a presentation by Mark Arbin. Opportunistic screening, which is that's prompted by the convenience of a healthcare visit, and that's an interactive process between a healthcare provider, usually a gynecologist or a family practitioner, and it's typically guideline driven. And perhaps the best example in the world in which opportunistic screening works and works very well is the United States, because there's a lot of resources to ensure that this is given as a practice guideline driven process. Elsewhere, and ideally, we would be able to have organized screening. Again, not a very common approach to be doing that, because it requires a centralized public health structure that would provide coverage, high quality coverage, as well as provision of resources for all women considered at risk. So it's the more equitable process of dispensing and screening, cervical cancer screening. And the examples, of course, of organized screening are primarily the Nordic countries. And this is a slide that you see over and over for the next 5 days, if you haven't already seen this slide, which shows the example of the Nordic countries, Denmark, Sweden, and Finland. They adopted that in the early 60s, whereas Norway adopted 10 years later, and you saw the impact that this had in terms of reducing cervical cancer incidence in these countries. And they have now gotten to be at the level that of low risk for cervical cancer. So adoption, this is ecological data, but shows clearly the adoption of a vigorous, high coverage screening program of high quality eventually does have an impact on cervical cancer incidence. And here's a more recent example, although not of recent past, but more recent than Scandinavian countries, was England, which had the dubious distinction up to the mid-80s of having the highest, among the highest incidence rates in Europe, in all of Western Europe. And eventually when they adopted their organized screening program with call, recall, and increased coverage to the levels that you can see in the blue line there, eventually they were able to reduce cervical cancer incidence to the levels that now are comparable to those of Scandinavian countries. So this pursuit of the mantra of coverage, which shows nicely with the negative correlation here between attaining high coverage and reduction and have an impact in cervical cancer, led to this mantra of pursuing high coverage. However, pursuing high coverage alone is not sufficient. Canada is a good example of how the intensity of efforts in covering cytology screening back in the 60s and eventually having an impact on reducing death rates. As you can see, there's a positive correlation. You can practically visualize a linear relationship between the different provinces with the level of intensity back in the 60s and eventually an impact in mortality from cervical cancer. But the same rationale without a high-quality program would lead to something like that, which is the impact in Latin America of attaining high coverage, and yet that didn't attain the high impact on mortality that one would have expected. So this pursuit of coverage alone without everything else that's part of a screening program has led to some of the screening failures that we have seen. Failure to reach the population at risk, inadequate quality control, infrequent screening, inadequate management of the abnormalities, treatment, and lack of sustainability. Ultimately, these are all things that eventually will be reasons for why it doesn't work. Now, if we look at 10 years ago, and we set ourselves back 10 years ago, and if you think about latency of disease, and at the time when all the disease started, and you just look at lineup of the top 10 countries in terms of high incidence rates for cervical cancer, in the bottom 10, you see some interesting commonalities here. The top 10 countries, you have Latin America, you have Sub-Saharan Africa, Caribbean represented. These are countries that have not only high fertility rates and all the conditions that would lead to high risk of the disease, but without the opportunity of having organized screening programs, high quality programs that would eventually raise that excess risk. If you look at the bottom countries, you also see an interesting pattern emerging. You have countries that are of common sociocultural norms, except for one of the countries, and which is Finland. Finland doesn't come to mind when you think about sociocultural norms of Muslim countries or Israel, which is also in that same list, except that Finland has the benefit of having one of the best organized screening programs in the world, which erases all of that excess risk that eventually comes from having the fun of the 60s, which they did have, and eventually led them to have everything that would lead them to have high risk of cervical cancer, but screening eventually erases that. The different case examples, case studies that we have from different countries here. So if you look at, there's more or less this distinction about 10 new cases per 100,000 women, which is some sort of threshold that differentiates high risk from low risk countries. You see here in the example, Brazil, the USA, which is an example of opportunistic screening, but has reaped the benefits over time. It's the gray line there. And you have Finland as our prime example of an organized screening program. And you have Brazil, one city, one registry in Brazil, showing. So you have the distinction. So even though you may have seen an impact of screening eventually, these countries are still at a somewhat high level of risk. So here's another cluster of countries here that includes the US, Canada, a lot of countries that have either robust opportunistic screening based on guideline-driven broad coverage, or countries that have organized screening programs such as the Netherlands, Denmark, Sweden, and Australia. As you can see, there's clearly the trend that around the 60s, more or less, eventually for a decline once PAP cytology became initially opportunistic and eventually adopted by many of these countries in an organized fashion, leading to the reduction that we see today, more or less clustering just below a threshold of 10 per 100,000 per year. So these are examples from other European countries that do not have organized screening programs or have just occasional or jurisdictional organized screening programs. And you see Austria all the way to Lithuania here. And as you can see, these are countries that have experienced some gains, but overall they cluster just above that midline of 10 per 100,000 per year. Here's an example now back to Latin American countries. Again, some of the countries that were shown in previous slides, they're way, way higher, above 20 per 100,000. examples that have been positive, such as Brazil, which shows a trend for decline, but still in rates that are intolerably high, considering what the resources that are available at the time. Brazil overall for the whole country has put a lot of effort since the 90s on extending coverage and putting a lot of vigor. But it was only in recent years when they actually put a lot of effort on quality, as you can see from the mid-2000 up until now, that we're just beginning to see a reduction in mortality from cervical cancer. So it's not an effort only in coverage that matters, but also coverage also in terms of everything else that matters in the screening program. Additional countries here from Southeast Asia, the example of Israel, which even without a tight and organized screening program, they have the low risk that comes from just the social cultural norms that they have in Israel, as well as in other Middle Eastern countries. Now, there's something we need to take into, when we look at these trends, it's important that there's a lot of confounding factors that eventually lead to increase and decreasing rates. I mean, if you throw back in the 60s, the sexual and feminist revolutions of the 60s, this is the mini skirt, and that's Twiggy, was the model for, I'm trying to remember the name of the woman who designed the mini skirt, something Mary Quant. Mary Quant, she's the designer. This was the symbol of the 60s, a politically charged decade in social activism and sexual assertiveness. So the advent of the birth control pill, which increases risk, this gradually replaced the other barrier methods. So all of these things that eventually entered increased risk of cervical cancer and contribute at the risk factor level. Women entering the workforce, eventually delaying childbearing, having fewer children, and asserting their sexuality. Smoking at the time was being perceived as a health threat for men, not for women, also again contributed to increased risk. But countering risk, eventually we also have PAP tests, which have just began to be used in clinical practice. Well, Julian Peters, a few years ago, 5 years ago, he dissected what was happening at the time, and he pointed out the fact that eventually it was the opportunity that the UK adopted right at the right moment the organized screening program, which averted a cervical cancer epidemic for the reasons that I alluded to in the previous slide. So all of the things that were contributing beginning more or less at the 60s, but that was exactly the very point that the countries eventually began organized screening programs. And England was about the last one to adopt that vigorously. And these are the projections of how many deaths of cervical cancer would have occurred. And as you can see in the statements, very, very sanguine statements from that paper pointing out to why this would have happened. If we look at the same situation in the US, which goes back with mortality data to the 30s, and I have here all uterine cancers because the cancers are not split in terms of mortality until the early 70s. But if you consider that most of the decline here were because of cervical cancer, which formed the vast majority of uterine cancers at the time, there was already a decline going on even before screening was widely adopted in the mid-60s as an opportunistic fashion, and nowadays more in terms of guideline-driven approaches. As you can see in the bottom two lines, you have split mortality for cervix and endometrial cancer, and showing clearly that now women are dying more frequently of endometrial cancer than of cervical cancer, whereas historically they tend to cross, the lines cross in some distant past, which is unknown to us. But look at the curve for lung cancer, where you see more or less an inflection there in 1965, which reflects the Second World War 20 years prior to that initial change in reproductive characteristics. Women took over the workforce in the United States and started smoking, which had an impact in lung cancer mortality. All of these things would also have had a pressure in cervical cancer mortality, as well as smoking would be a risk factor also for cervical cancer. So this is just to give you a medley of different things, some happening, some helping to increase rates, some helping to decrease rates, that one would have to take into account for different countries to be able to understand what these trends, how these trends should be considered. So this is my last slide here. I just want to summarize the things that the take-home messages. Cervical cancer screening is not a trivial undertaking. It's a very complex activity that requires integration of resources and processes that it suffices to have one failing for the whole process of screening to fail as well. Quality control, coverage, treatment, and follow-up, all of these things have to work in sustainable fashion and for a long range. Fully organized screening is a rare bird. It doesn't happen everywhere. We have few great examples, and it may be an unattainable reality because of cost and because of the political decisions in the healthcare system in different countries, but it is certainly the most equitable and efficient way of deploying secondary prevention for cervical cancer. Audit studies are one way of eventually seeing if screening works, and those that are done in the UK and Finland are outstanding in terms of allowing opportunities for reaching programmatic decisions. A cheaper way of doing that is just to monitor incidence and mortality trends, but as I've shown you, there are the caveats that one must take into account. They are jurisdiction specific with respect to what would confound our interpretation of how trends will go up or go down. Thank you very much.